Hello everyone, and welcome to today's live broadcast, Assessing Risk in Cervical Cancer Screening Management, the Role of HPV Genotyping, presented by Dr. Catherine Behrens. We're excited to bring this educational web seminar presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. This webinar is sponsored by Roche Diagnostics. Roche is a leader in research-focused healthcare with combined strengths in pharmaceutical and diagnostics. Roche is the world's largest biotech company with truly differentiated medicine in oncology, virology, inflammation, metabolism, and CNS. Roche is also the world's leader in vitro diagnostics, tissue-based cancer diagnostics, and the pioneer in diabetes management. I'm Susie Valdez of LabRoots, and I'll be your moderator for today's event. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during this presentation. Just click on the green Q&A button located at the lower left of your presentation window and type your question into the box that appears on the screen. We'll answer as many questions as we can until the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, just click on the screen icon located on the lower right. If you have any trouble seeing or hearing this presentation, please click on the support button at the top right of this presentation window, or use the Q&A button and let us know you're having a problem. This is an educational webinar that offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of your web page and follow the process of obtaining those credits. And now I'd like to introduce our presenter, Dr. Behrens. Welcome.
Everyone, and thanks for taking time out of your schedule to join us for this presentation. Today I'll be talking about how we might be able to improve the way we screen for cervical cancer by using HPV genotyping to assess each woman's individual risk. By the end of the presentation, I hope that we can see that genotyping allows us to better triage our patients into categories of management, those who can confidently be discharged to the next round of routine screening, those who need immediate follow-up, and those who can be deferred to short-term follow-up. My disclosures. Now, on the agenda, we'll first review briefly the background of HPV and cervical cancer. We'll then look at how genotyping has been incorporated into the guidelines, how genotyping can be used for risk management, and also how risks of progressing from precancer to invasive cancer may vary for different genotypes. Finally, we'll discuss how genotyping plays a key role in the strategy that uses HPV as the first-line primary screen for cervical cancer. So let's begin with a brief review about what we know about HPV and cervical cancer. We know that more than 99% of cervical cancers are caused by HPV. And of the 13 or so oncogenic types, HPV 16 and HPV 18 are responsible for approximately 70% of invasive cancers. We also know that HPV is the most common sexually transmitted infection. Approximately 80% of women will be infected sometime during their lifetime. And the vast majority of these women will clear the infection without any consequence, but we know that persistence of infection increases the risk for cervical disease. We know that cervical cancer is the third most common cancer in women and the fifth cause of cancer deaths worldwide. And despite screening, in the US, we'll see approximately 13,000 cases and 4,100 deaths a year. And globally, the statistics are staggering. About 500,000 new cases and more than 250,000 deaths each year worldwide. But the cervical cancer story isn't all bleak. Make no mistake, cervical cancer screening is one of the biggest success stories in disease prevention. As this slide shows, data from the NCI SEER database demonstrates a significant decrease in both incidence and mortality rates from cervical cancer since the adoption of the Pap smear into organized screening programs. But if we look a little closer, we notice that there has been a plateauing of this decrease in the last decade. And this raises the question of whether we have reached the limitations of screening with cytology. If we look at the box at the bottom, we notice too that the 5-year survival rates over the same period of time have shown very little difference. The 5-year survival in 1975 was 68.1%, and in 2010, 67.9%. So again, that raises the question of whether we can improve on screening methodology. Now, if you made the argument that the plateauing of the decreased incidence and mortality that we see is because we haven't been able to reach every woman for screening, you would be correct. This slide shows the results from studies done at 2 well-organized screening programs, Kaiser and the Swedish National Health Service. For this study, the medical records of women with invasive cervical cancer were reviewed to evaluate their screening history prior to being diagnosed with cancer. As you can see in the first line, the majority diagnosed with cancer had not had the appropriate screening. But if you look at the second line, you see that a high percentage had had cytology, but that it failed to detect any abnormality. At Kaiser, this was 1/3 of the women with cancer, and in the Swedish study, it was 1/4. Now, this type of data caught the attention of the U.S. Preventative Services Task Force and prompted them to commission a study to compare the sensitivity of HPV to cytology for the detection of precancer. In this slide, we see the results of that meta-analysis. As you can see, in each of the 6 studies, HPV was found to be more sensitive than cytology. And in fact, on average, HPV was nearly 36% more sensitive. Unfortunately, HPV, although sensitive, is not very specific, and that would have to be addressed if it were to be used as a screening strategy. And we'll discuss that in more later in this presentation. Now let's spend a few minutes reviewing some specifics about HPV genotypes. Among the 40 or so HPV genotypes that infect the anogenital area, as mentioned in the introductory remarks, there are about 13 genotypes that are classified as high risk or oncogenic. This diagram is a phylogenetic tree that shows the relationship of the anogenital types, and this relationship is based on how similar their DNA sequences are. The known high-risk types are shown in black, those classified as possibly high risk in teal, and the low risk in dark blue. All the high-risk types can be found in the 2 most important HPV subgroups, or clades, A9 and A7. A9 includes HPV 16 and other related types, while A7 includes HPV 18 and its sequence similar types. The clades take on significance in that when cross-reactivity occurs with HPV vaccines, HPV 16, for example, will cross-protect against the members of clade 9 and HPV 18 against members of clade 7. So what is the significance of the various genotypes to screening? This slide shows results from a study conducted at Kaiser Permanente, Portland, that was the first large prospective study to examine whether the value of HPV testing could be optimized by using separate detection of the most important genotypes. In this study, women had their HPV status determined at baseline and then were followed for 10 years to see what their risk of developing CIN3+ would be. Now, for those not familiar with the terminology, CIN is an acronym for cervical intraepithelial neoplasia. CIN3 represents the highest stage of CIN. CIN3+ includes CIN3, adenocarcinoma in situ, and invasive cancer. And CIN3+ is often used as a surrogate for cervical cancer. But as you can see on these graphs, women who were infected at baseline with HPV 16, and that's the red line, had the highest risk of developing CIN3+ over 10 years. For HPV 16, that was over 17%. For HPV 18, the blue line, the risk was 13.6%, and the risk for the remaining genotypes was only 3.0%. And you can also see that the risk in women who were tested HPV negative at baseline was less than 1%, 0.8%. Okay. Now, as was mentioned in the introductory comments, HPV 16 and 18 are responsible together for 70% of cervical cancers. And that estimate comes from the data published by Dr. San Jose from Spain, who determined the genotype distribution in invasive cervical cancers from 38 countries, testing more than 20,000 cancer specimens. This stacking graph shows the distribution in squamous cell cancers, and we can see that most, 62% of the cancers, are HPV 16 positive, while only about 8% of squamous cell cancers are 18 positive. On the other hand, in adenocarcinomas, we see that HPV 18 is responsible for a much higher percentage, 32%, and together with HPV 16, they account for more than 80% of invasive cancers. We also see on this next slide, that is also from Dr. San Jose's data, that the 70% combined contribution of HPV 16 and 18 holds true globally, although the proportion of cancers distributed between 16 and 18 may vary slightly from continent to continent and over multiple races and ethnicities. We see that 16 and 18 are consistently responsible for about 70% of the cancers. But what can we say about the remaining 30% of cancers? Are there other genotypes that are major contributors? For example, HPV 45 has received considerable attention. Now we can explore this question using data from the Athena study, a large US screening study that enrolled more than 47,000 women. This bar graph shows both the prevalences and risk of CIN2+ and CIN3+ for each of 5 genotypes in women 30 years and older. Not surprisingly, HPV 16 and 18 have the highest risk, but HPV 31 is only slightly lower, followed by HPV 33, with HPV 45 having a relatively low prevalence and risk. It's also worth pointing out that only genotyping with HPV 16 and 18 is supported by the current guidelines. Now this next slide shows similar results from Dr. Schiffman at NIH, who analyzed data from 20,000 women who were followed at Kaiser Portland for up to 15 years. If we look at the graph, we see agreement with the Athena data in that HPV 16 imparts the highest risk, followed by HPV 18, and then 31. Of note, HPV 45 again did not show a risk distinguishable from the remaining genotypes. Now Roche's R&D group was aware of data like these that demonstrated the oncogenicity of HPV 16 and 18, and they specifically designed an assay that optimized screening to identify women at the highest risk. So the system they designed for Cobas HPV reports out not only pooled HPV status, but it also provides separate results for HPV 16 and 18, not as a reflex test, but as an integrated result that is reported out simultaneously with the pooled result. And the way this is accomplished is with a 4-channel system that is diagrammed on this slide. The first channel reports out results for the non-16-18, 12 other genotypes. The second channel for HPV 16, the third channel for HPV 18, and the fourth channel is an internal beta globin control that confirms the presence of DNA and the absence of inhibitory substances. So next, let's talk about genotype, about how genotype has been adopted into the evolving guidelines for cervical cancer screening. This slide from the American Society of Colposcopy and Cervical Pathology shows the original algorithm for managing co-testing results in women 30 years and older. Now, the challenge with co-testing is that often one of the co-test partners will be positive and the other negative, and this means that an additional management decision is necessary to resolve the discordance. In this algorithm, we are evaluating women who have had co-testing with a negative cytology result, and I should mention this is another algorithm, NILM, that stands for negative for intraepithelial lesion or malignancy. Now, there's no question that a negative cytology and a negative HPV yield a clear negative result, and as a consequence, these women can be dismissed from screening until the appropriate interval for rescreening, as is diagrammed on the far left. However, in the case of a negative PAP and a positive HPV result, additional evaluation needs to happen, and that's indicated by the next arrow to the right. In 2006, the guidelines recommended a repeat co-test in 12 months, but this deferred management was problematic for both patient and clinician, raising anxiety on both parts. The other issue with this deferred strategy is that loss to follow-up that can occur during the 12-month period, and it is well documented that on average, approximately 20% of women will be lost to follow-up in cervical cancer screening programs. But once HPV assays with genotyping became available, clinicians had an alternative to deferring women with negative PAP but with positive HPV results. In 2009, ASCCP revised their guidelines to include the option of co-testing with genotyping, that is, cytology performed along with HPV test that would also provide specific results for HPV 16 and 18. In this algorithm, again, women negative for both tests are returned to routine screening, while women with negative cytology and positive for either HPV 16 or 18 are sent to immediate colposcopy, since they have been identified to have the highest risk of having high-grade cervical disease. Then we see that only those women who are positive for the non-16-18 less oncogenic genotypes are deferred to 12-month follow-up for repeat co-testing. This co-testing with genotype option eliminates both some anxiety and also the possibility of loss to follow-up of women who are at the highest risk. I think most clinicians agree that this is a step towards optimizing cervical cancer screening. Now, following along with the evolution in guidelines, in 2012, unprecedented joint guidelines were issued by 3 major professional organizations: the American Cancer Society, ASCCP, and the American Society for Clinical Pathology. There were many changes proposed, but one of the major changes was to advise that co-testing, rather than cytology alone, was now the preferred strategy for screening women 30 years and older. As you can see in this joint publication, the recommendation for co-testing also endorsed the option of triaging women with negative cytology with HPV 16 and 18 positivity to colposcopy, rather than deferring to 12-month follow-up. Now that we've seen how HPV 16, 18 can optimize screening by identifying women at the highest risk for high-grade disease, and that the guidelines support the use of genotyping, let's speak more specifically about how genotyping can be used to quantitate women's risk and individualized management strategy. Now this slide again will show data from the Athena study, and it provides important information for managing co-testing results in women 30 years and older who have a negative PAP but who are HPV positive. Here we'll be looking at the absolute risk of CIN3+ stratified by the results from the various Cobas HPV channels. And I should mention that throughout this presentation that I'll be primarily showing data for CIN3+, since it is less likely to regress than CIN2+, and therefore represents more clinically relevant disease. Now we see in this first bar that if we look at the absolute risk of a negative PAP independent of HPV, it's pretty low at 0.5%. And if we add to that a negative pooled high-risk HPV, that's all the 14 genotypes, we see that the absolute risk is lower still, 0.3%. On the other hand, a positive pooled HPV raises the absolute risk to about 4%. But the real risk stratification is apparent when we look at the Cobas HPV categories. We see that the 4% risk is better defined. For example, if HPV is positive for the 12 other types, the absolute risk decreases to about 2%, while an HPV 16 positive result raises the absolute risk to nearly 12%, and HPV 18 imparts an intermediate risk of about 6%. So keep in mind, these are all risks for women with negative PAPs. That means that without the genotyping option for managing discordant co-testing results, women with a negative PAP and a positive for pooled high-risk HPV would be deferred to follow-up in 12 months. Yet, if a woman is 16 positive, she has a 12% absolute risk for CIN3+. Or another way to look at it is 1 out of 8 women with a negative PAP who is 16 positive has CIN3+. To me, as a gynecologist, it was startling to see that the risk was so high and that we were also adding to the risk with the possibility of loss to follow-up with deferral. We can also look at the stratification when HPV testing is used as an adjunctive test to ASCUS cytology. Although the guidelines advise the risk of ASCUS cytology with any positive HPV result is high enough to warrant referral to colposcopy, it's still helpful to quantitate the risk stratified by the various HPV types. In this slide, again, we're looking at the absolute risk of CIN3+, but now in women with ASCUS cytology rather than a negative PAP result. We see that the absolute risk for CIN3 with ASCUS cytology independent of HPV is about 3%, and that this decreases tenfold to 0.3% if the pooled HPV result is negative, which is why women with ASCUS cytology who are HPV negative are not sent to colposcopy. On the other hand, the absolute risk increases to more than 8% if pooled HPV is positive. And again, that's a risk felt to be high enough to warrant referral to colposcopy. And we'll speak more about that, about the risk cut points for management decisions in a few minutes. Now we can stratify the 8% risk further with Cobas results that indicate that if HPV positivity is due to 12 other genotypes, that the risk decreases to half, about 4%. However, in women who are HPV 16 positive, the absolute risk for CIN3+ is highest at 21, and again an intermediate risk for HPV 18 at about 4%. And so, although the genotyping with ASCUS cytology will not be used to decide which women go to colposcopy, the risk stratification is helpful in guiding post-colposcopy management. Since the majority of women with ASCUS cytology who are pooled HPV positive will not be found to have high-grade disease on colposcopy, the risk stratification can help identify who is at highest risk and who might need close follow-up or more intensive efforts to assure compliance with follow-up. As long as the genotype results are generated automatically with Cobas HPV, not as a separate reflex test, why not incorporate it as a factor in the individual risk profile of each patient? And that helps us segue into the next section of the presentation, where we'll discuss more specifically the risk assessment model for cervical cancer screening. So we've seen how the Cobas HPV test or other HPV assays, which genotype as a reflex test, can help stratify risk. But now we can look more specifically at a model of risk assessment for cervical cancer screening that is beginning to emerge as more technologies for screening are developed. At present, we have only cytology, HPV testing with partial genotyping, and histology as tools. In the future, in the US, we will also have more sophisticated imaging systems, as well as biomarkers, such as P16, Ki67, and methylation. And these likely will be used in algorithms to calculate a risk for each woman based on all of her screening results. So now I'd like to review how the risk assessment model works today with the existing technologies. So we'll be familiar with the concept when more sophisticated algorithms incorporating newer technologies are introduced. Now in 2007, Dr. Castle proposed a risk assessment model based on cytology, pooled HPV, and remember HPV genotyping assays were not yet developed, and histology. In this colorful slide, we see how he assigned a risk, and this is again for CIN3+, based on results from the existing technologies used for screening. It was really the first attempt to quantitate risk and assign management strategies based on the magnitude of that risk. For example, it was proposed that a woman with a risk of CIN3 below 2%, as determined from her screening results, for example, negative cytology or negative HPV with ascus cytology, was considered sufficiently low to allow her to have routine follow-up. A risk at or above 10%, and that would be for LSIL or HPV positive ascus, warranted immediate colposcopy, while those with risks between 2 and 10%, for example, HPV positive, cytology negative, could be deferred to short-term follow-up. On the higher end of the spectrum, those with a risk greater than 40%, and note that this is a compressed scale, for example, HSIL would have a risk that high, could be counseled about proceeding to immediate treatment. In 2006, Dr. Castle expanded on his risk assessment model to include HPV genotyping. And on the next several slides, I will be showing data from his recent publication that looked at CIN3+ risks in women with negative PAPs at 1 year, which would be the risk if co-testing without genotyping was practiced. This is similar to the risk stratification from the Athena data that we looked at before, but I think it's helpful to see it again in the context of the Castle risk assessment model. So we see here, if we have, for example, HPV positive and cytology negative, the risk is below 10% and would not warrant immediate colposcopy. However, with the genotyping option, we could see that the HPV, if positive for HPV 16 and cytology negative, would give an absolute risk above 10%, and that would warrant immediate colposcopy. We see something similar for HPV positive in ascus cytology. The risk is approximately 10%, and that warrants immediate colposcopy. But with the genotyping option, we see that the risk, if the HPV was positive for HPV 16, rises to about 20%. And again, this would be useful for the management in post-colposcopy. We see similar results for HPV positive LSIL and HPV 16 positive LSIL. And of course, with HPV positive LSIL, the risk to begin with is very high, above 40%. And with HPV 16 HSIL, the risk rises to nearly 80%. So again, consideration for immediate treatment could be considered. And we see similar risk stratification with HPV 18. Now, the next topic that I'd like to cover has to do with using CIN3+ as a surrogate for cervical cancer. As mentioned before, CIN3+ includes CIN3, adenocarcinoma in situ, and cancer. Now, in order to calculate risks, whether it be for cytology or HPV results or newer technologies that will be used in the future, it's necessary to conduct large studies that generate adequate numbers of disease cases. And although we'd like to be able to calculate accurate risk for developing invasive cancer, obviously that's the ultimate endpoint, there are not usually sufficient cervical cancer cases detected in the studies that allow us to calculate the risks, at least those studies that are conducted in developed countries. So that's how we came to use CIN3+ as a surrogate for cervical cancer. For the most part, CIN3+ serves as an adequate surrogate, but I'd like to present some additional data from the same group in Spain we saw earlier, who determined the HPV genotype status of the cervical cancers globally. This study here looked at the percent HPV positivity at various stages of cervical disease, which is shown on this graph. I'd like to focus on the right side that uses the histology diagnosis to define disease stage. We can see that the HPV positivity of HPV 16 rises sharply, that's the blue curve, through all stages of disease, and in particular from CIN3 to invasive cervical cancer. We see a similar trend for HPV 18, the red line, but then a fairly flat line for HPV 45, it's the green line. Looking at the data this way seems to indicate that not all CIN3 has the same tendency to become invasive cancer. This concept can also be expressed by looking at the invasive cancer to normal ratio, which will be higher with the more oncogenic genotypes. And you can see that to the right. The next graph shows us similar plots for additional genotypes, which again on the right side show even sharper declines in percent positivity, for example, for genotypes 31, 33, and 52. ICC to normal ratios likewise are much lower than for HPV 16 and 18. Now, this isn't to say that these other genotypes can't cause invasive cervical cancer, but rather their oncogenicity may be less than HPV 16 or 18. And this isn't unexpected, since as we discussed, these two genotypes are responsible for 70% of all cancers. We looked at a similar analysis from the Athena study, where a much lower number of invasive cancer cases were detected than in the study from Spain, so we had to use CIN3+ as the endpoint. But interestingly, we saw much the same trends. There was an increase in positivity from CIN2 to CIN3+ for HPV 16 and 18, and those are the blue and red curves, while the remaining genotypes showed a fall off. As for HPV 31, which we saw demonstrated a risk for CIN3+ that was similar to HPV 16 and 18 in both Athena and the Kaiser Portland studies, but here it shows a downward curve as disease progresses. So we may need additional data before we can say whether HPV 31 should be given the same aggressive response as HPV 16 and 18 warrant. And keep in mind again that HPV 16 and 18 are the only genotypes that are currently supported by the guidelines for risk assessment. Now, I'd like to take the last few minutes of this presentation to illustrate how genotyping and risk assessment are used in a practical and timely application. As you may be aware, the FDA granted approval in 2014 for HPV to be used in women 25 years and older as the first-line primary screen in cervical cancer, and HPV genotyping plays an important role in that strategy. Before we discuss the specifics of the primary screening algorithm, I want to step back for a minute and review the reasoning behind using HPV rather than cytology as the primary screen and the challenges that that presents. First, it has been pretty well established that HPV is more sensitive than cytology for the detection of precancer. We saw that in the slide from the U.S. Preventative Service Task Force meta-analysis. But we also know that HPV has limited specificity. Surely not all women who have HPV infection go on to develop cervical disease. And in any screening strategy, it makes sense to use the more sensitive test first so that we cast the widest net to capture all who may be at risk. But we need to follow up that sensitive test with a more specific triage, or we risk overmanaging and overtreating patients. While working on a primary screening strategy, it became clear that an algorithm would need to be developed that provided the best balance between sensitivity and specificity. So I'd like to review how we came to develop a balanced strategy, one that received FDA approval and is supported by several professional societies. And you'll see how HPV 16/18 genotyping plays an integral role in this strategy. This build slide will show the FDA-approved algorithm for HPV primary screening using the Cobas HPV test. Let's walk through it and see how we were able to use 16/18 genotyping to help provide the balance of sensitivity and specificity that we needed. As diagrammed, we start with Cobas HPV tests. And those women who test HPV negative can confidently be dismissed to routine follow-up in 3 years. We know that more than 99% of cervical cancers are attributed to HPV, so it makes sense that if an HPV infection isn't present, that there's very little risk of cervical disease. We also saw in data from Athena that I didn't present today that the risk of CIN3+ over 3 years with a negative HPV result is very low, 0.3%, well below the threshold for colposcopy or even short-term follow-up. Now, those who test HPV positive, we know that if it's HPV 16 or HPV 18, those are at the highest risk, so they'll proceed to colposcopy. Now we have the remaining women who test for the 12 other non-16/18 to triage. And again, this would be a high percentage of women to send to colposcopy, so those are triaged with cytology. Those who have abnormal cytology would go to colposcopy, and those with normal cytology would be deferred to short-term follow-up since they're still HPV positive. Now, to address the concern that HPV isn't specific enough and that it would send too many women to colposcopy, we can evaluate that by looking at the percent calculated for each result in the screening strategy. We see that approximately 90% of the women will test HPV negative and will be sent to routine follow-up. Of the 10% that are HPV positive, only about 4.7% would be referred to colposcopy. That's the 2.9 plus 1.8%. And that is compared to cytology as the first-line screen, where this percent can be considerably higher depending on your lab's percent for abnormal cytology. And we'll return to the issue of sensitivity and specificity of primary screening with additional data over the next few slides. Now, to illustrate that HPV primary screening provides improvement in sensitivity while maintaining specificity, I'd like to compare primary screening performance to the two current accepted strategies, cytology alone and cotesting. Now, cytology will include HPV triage ASCUS so that HPV negative ASCUS cytology women are not taken to colposcopy as per guidelines. And we'll also compare to a hybrid cotesting strategy that requires a little explanation. Since HPV primary screening is approved for women 25 years and older, but cotesting only for women 30 years and older, we used a hybrid cotesting strategy where women 25 to 29 were screened with cytology alone, and those, sorry, little slide problem here, and those 30 and older with cotesting. Now in this slide, we will see a build of the comparisons of performance parameters for all three screening strategies. Sensitivity and specificity are expressed relative to the sensitivity and specificity for cytology. So those parameters for cytology will be defined as 1. For the positive predictive value and negative predictive value, we use the actual values. We see that for the hybrid strategy, sensitivity relative to cytology is 1.28, meaning that it was increased by 28%. Specificity was equal to cytology, and NPV was slightly higher. Now for HPV primary screening, we see an even greater increase in sensitivity, 40% higher than cytology alone, and 12% higher than the hybrid cotesting strategy. And both are significant increases. It's a little counterintuitive to see that the sensitivity for HPV primary screening is higher than cotesting, but again, remember that the hybrid cotesting strategy includes the cohort of women 25 to 29 who just had cytology screening per the guidelines. And specificity for primary screening is not lower than cytology alone, while PPV and NPV are improved over both cytology alone and cotesting. So we took the comparison one step further and wanted to see how the strategies would perform in a clinical situation. For this, we compared the number of CIN3+ cases detected, which is a clinical measure of sensitivity, the number of tests required by the strategy, and also the number of colposcopies expressed both as the total and as the ratio of colposcopy per CIN3+ detected, which is a clinical surrogate for specificity. As we can see, HPV primary screening detects the highest number of CIN3+ cases, required only slightly more tests than cytology alone, and nearly half as cotesting. And although it required the most colposcopies, when expressed as the ratio of colposcopy to CIN3+ detected, it's no higher than cotesting. Now, since we've definitely reviewed a lot of data in a short time, let's see what conclusions we can draw. First and foremost, cervical cancer is a preventable disease, and that can't be stressed enough. It provides the perfect model for screening. We know what causes it. We have good screening tools, which improve over time with new technology and new strategies, such as primary screening. We're also fortunate that the cervix is accessible to biopsy so that we can detect precancer. In addition, we have good treatment options when precancer is diagnosed, and it's also an indolent disease with a long precancerous stage that allows for adequate time to screen, diagnose, and treat. So this is truly the low-hanging fruit of preventable disease. The second conclusion I want to propose is that HPV with 16/18 genotyping, and it remains to be seen if additional genotypes will be elevated to a similar risk level, is a valuable tool that allows us to identify who is at the highest risk and would benefit from immediate colposcopy, and conversely, who is at lower risk and can confidently be referred to routine or short-term follow-up. And in co-testing, 1618 genotyping also has the advantage of decreasing the loss to follow-up of those women with significant disease, since we avoid deferring their assessment for 12 months. And lastly, 1618 genotyping, if in the primary screening strategy, provides the balance of specificity to the improved sensitivity, and as such, primary screening offers another option to optimize screening. So in closing, I'd like to thank you for your attention and for your continued efforts to promote the prevention of cervical cancer. And I'll turn it back over to Susie now.
Thank you, Dr. Behrens, for that informative presentation. It's time for our Q&A now. If you have any questions you'd like to ask Dr. Behrens, please click on the green Q&A button at the lower left of your presentation window. Type in your questions into the box that appear on that screen and click and send the button. We'll answer as many of your questions as we have time for. If we are unable to get to your question, Dr. Behrens will follow up via email after the presentation. So let's start with our first question. Dr. Behrens, do you think that additional HPV genotypes other than 16 and 18 will be adopted into the guidelines for triaging cytology negative HPV positive results in co-testing?
Well, that's a great question, Susie. And I think first to address the technical issue, there is at present no HPV assay that's FDA approved that can identify any other genotypes besides HPV 16, and there's one assay that identifies HPV 18 along with 45. So until that assay is developed and FDA approved, nothing will happen. If that should occur and other genotypes can be detected with an FDA approved test, I think it'll take some time for that to get into the guidelines. The guidelines require a fair amount of data, and as we saw through the presentation, the prevalence of these other genotypes is fairly low. So it's very difficult to do studies that have adequate numbers of women infected with genotypes other than 16 and 18 with significant disease, so that we can show that their risk is high enough to warrant going to immediate colposcopy. So I think to summarize the response, time will tell whether other genotypes make it into the guidelines, but first we need an assay that's FDA approved to identify them, and then a fair amount of data to convince the people who make the guidelines that this warrants being in the guidelines. So this will take some time.
Thank you for that response, Dr. Behrens. Here's another great question from an audience member. Why is the rescreening interval 5 years for a negative co-test and 3 years for a negative HPV primary screening result?
I'll start with the primary screening. The reason why in the US the rescreening after a negative HPV primary screen is 3 years is because that is what was shown in the Athena data. As I mentioned in the presentation, a woman who had a negative HPV test at baseline at 3 years had a risk of CIN3 plus of 0.3%. So the Athena data was able to show the safety of a negative HPV test over 3 years. Now, for co-testing, it was decided that a 5-year interval with both partners of the cotest, the cytology and HPV being negative, would be appropriate was because that risk was similar to what the risk would be for a pap smear at 3 years. And they felt that that, should be the gold standard. I should mention, though, that even though the screening interval for a negative cotest is 5 years, that many clinicians, if not most clinicians, are very uncomfortable with the length of that interval. They seem to be much more comfortable with a 3-year interval, which is what is recommended with negative HPV as the primary screen.
Thank you for that. We have a lot of great questions coming in, but we only have time for one more. Dr. Behrens, you mentioned that you focused only on a risk for developing CIN3+, since it is more clinically relevant disease. But isn't the threshold for treatment in the US CIN2+?
Yes, up until the 2012 new guidelines that I had mentioned were unprecedented joint guidelines, the recommendation had been traditionally, at least in the US, that the treatment threshold be CIN2, and that allowed for, a little bit of error, in favor of giving the patient the benefit of the doubt in case the CIN2 was really CIN3. However, in the 2012 guidelines, the recommendation was made that certainly in younger women, the threshold should be raised to CIN3+, and that it should be considered depending on the patient's situation. Now, of course, if you have, a 45-year-old woman who's completed her childbearing and has had, persistent CIN2, then her clinician may decide that the best treatment for her would be to have an excisional or an ablative treatment for CIN2. But for the most part, the trend is going towards treatment threshold of CIN3+, particularly in young women prior to childbearing.
Dr. Behrens, thank you again for this very important and informative presentation. Do you have any final comments you'd like to share with the audience?
It's just to again thank them for their attention and for their diligence in screening women for cervical cancer, because again, we can't stress enough that this is a preventable disease, and we would like to see a continuation of the decrease in the incidence and the mortality, not only here in the US, but globally as well.
Thank you again, Dr. Behrens. I'd also like to thank LabRoots today for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available on demand viewing through July 2017. You will receive an email from LabRoots letting you know when this webcast will be available for replay. Please share this announcement with your colleagues who may have missed today's live event. That's all for now. Thanks for joining us, and we hope to see you again soon. Bye-bye.